Argentina, meeting with you all today on behalf of the American College of Cardiology, and with thanks to our hosts, the Argentinian Society and the Argentinian Federation. It's really been enjoyable to meet all of you before this meeting here today. And what I'm going to do is lead into talking about cardiovascular risk factors and the importance of cardiovascular risk assessment and utilize the paradigm of what's happening in our country, but also, most importantly, focus on the challenges here in Argentina. As mentioned previously, this presentation is supported by Pfizer in collaboration with the American College of Cardiology, the Argentinian Society of Cardiology, and the Argentinian Federation of Cardiology. I have no conflicts related to my presentation today. This is mi familia, and I will tell them all about my great visit here to your country. So there are three objectives that I'd like to focus on here related to cardiovascular risk and risk assessment. The first is going to highlight the importance of a comprehensive risk assessment, recognizing that many of our patients, as pointed out already today, have multiple cardiovascular risk factors, and this can compound risk. We'll talk about how to utilize a population-based risk assessment tool, and it'll be interesting to know which of these tools you utilize in your daily practice. And then I will complete my presentation talking about how to best apply this risk assessment to a patient case and partner with our patients in shared decision making. So I'm going to talk initially about the burden of cardiovascular disease and cardiovascular disease risk factors. And as you well know, that about 18 million people a year die from cardiovascular disease, and global mortality related to cardiovascular diseases continues to increase despite the wealth of our knowledge base, new approaches to care, and new technologies. Most of this increase is happening in low and middle income countries. We already heard from our two previous speakers about the burden of cardiovascular disease in Argentina. And although this burden has leveled off and we see improvements, cardiovascular diseases still remains the #1 cause of mortality in both men and women in your country. This pie chart here emphasizes again that the majority of deaths in your country are related to non-communicable diseases, with heart disease still leading the pack. In our country, this is a graphic demonstration of what has happened to cardiovascular disease mortality in the U.S. really over the last century. And cardiovascular diseases in our country rose dramatically, peaking in about the 1970s and 1980s. And as a personal story, my grandfather on my mother's side, he died from cardiovascular disease in 1976, so right about the peak of death from cardiovascular disease in our country. And this is one of the reasons that really spurred me on to focus my career on cardiovascular prevention. If we look at population-based measures, and we recognize that in any given population, there's a bell curve distribution among risk factors, and as physicians and as caregivers, we care for patients when they're having acute illnesses, and we hopefully focus on their prevention. But this slide really points out the power of public health initiatives or population health. So if we take this bell curve distribution of any factor, whether it be obesity, waist circumference, BMI, tobacco use, hypertension, and we nudge this bell curve distribution a little bit more to a healthier place, we really have the ability to save more lives than we can through episodic and individual healthcare delivery. Well, the U.S. has looked at as an example of how you can decrease cardiovascular deaths. And what has happened over the last 2 decades is that we have reduced cardiovascular deaths by about 350,000 individuals. This is a well-known paper by Ford, published in the New England Journal of Medicine now about a decade ago. And if you look at the data, despite our population becoming more obese and having increasing rates of diabetes, much of like what is happening now in Argentina, the benefits that we have accrued in our country over the last 2 decades have predominantly been related due to cardiovascular preventive efforts. So if you add up those numbers here, the benefits have been related to drop in blood pressure, smoking, better diets and exercise, lower levels of cholesterol, and aggressive secondary preventive efforts. This is the central figure of a paper we published in the Journal of the American College of Cardiology now 2 years ago. And this paper looked at defining, promoting, and impacting cardiovascular population health, the health disease continuum. Let me see if I have a pointer. Yeah, there we go. So really, as cardiovascular specialists, we are often encountering our patients out here. We're finding a disease, often at a late stage, and trying to save lives, improve quality of life. But it will become more and more important for us to better understand what it means to be healthy versus diseased, with a greater focus on health promotion and disease prevention. I'll transition now into primary prevention in ASCVD and the importance of targeting multiple cardiovascular risk factors. This is InterHeart, and InterHeart looked at 56 countries, 6 continents, and about 30,000 individuals. And the story of why people have myocardial infarction is similar everywhere in the world. The majority of myocardial infarctions are predicted by 2 factors, smoking and lipid problems, or the ratio of ApoB to ApoA. But some important things that were pointed out in InterHeart are the population attributable risk to many factors. Our previous speakers talked about diet, exercise, blood pressure. Really, hypertension worldwide has the greatest population attributable risk to cardiovascular morbidity and mortality. And a highlight of InterHeart was the importance of obesity, but also psychosocial cardiovascular risk factors, and we underappreciate this. It is as important as having diabetes in our patients. When we look at primary prevention, we know primary prevention is as easy as ABCDE. You say ABCDE. See? A focus on risk assessment, and I'll take you through that here today. Also, A stands for appropriate antiplatelet therapy in primary prevention, and the U.S. Preventative Task Force highlights that this should be appropriate, the benefit outweighing the risk, when your patient's risk is about 10% over 10 years. B for blood pressure, and I know our American blood pressure guidelines were released just recently, the American Heart Association, and maybe we'll have a chance to discuss these some in our panel discussion. C, cholesterol, and cigarette, tobacco cessation. D for diet and weight management, diabetes prevention and treatment, and E for exercise. What we want to really focus on when we see an individual patient is we assess the totality of their risk, and we really want to mirror or match the intensity of our risk prevention efforts to the risk of that patient. Let's see, there we go. So when we think about assessing a patient's risk, we need to be familiar with several terms. One term is absolute risk. So this is a defined risk over a defined period of time, and this is the risk we think about when we do risk estimations through the tools we have for population risk assessment. We also want to understand the concept of relative risk. So you can be a 10-year-old boy in Argentina, be obese already, a very poor diet, already have elevated blood pressure compared to the other 10-year-olds and lipid abnormalities, and that individual's absolute risk will be very low because they're 10. But their relative risk compared to their peers will be very high. So we want to be able to identify those. More recently, a term called lifetime risk is one that's an important concept. Donald Lloyd-Jones, one of our colleagues in the world of prevention in the U.S., has described that we can think about a middle-aged person and calculate the potential risk of that individual throughout one's life. Here we see, first of all, if you have no cardiovascular risk factors, your lifetime risk is actually very low. That's absolutely no risk factors, and unfortunately most Americans, and I would imagine most people from Argentina, when you're middle-aged, you do not have zero risk factors. But what's also pointed out here is the great rise in risk when you add one risk factor to two, to three, to multiple, and we think about this as a concern because lifetime risk in individuals with multiple risk factors can approach 70% in men and more than 50% in women. So this is the discussion point with your patients as you talk about their absolute risk. Although it may be low, you can tell them that their lifetime risk is quite high, and this sets the stage for an ongoing risk discussion. I already mentioned that we should be paralleling the intensity of our risk efforts to the cardiovascular risk of our patients. And so, although risk reduction occurs at every level of risk in proportion, we get the most effective risk reduction in the highest risk population in terms of our net clinical benefit. What I'd like to do now is talk about risk assessment and get a sense of what you're doing in risk assessment, take you through a case, and we'll demonstrate the importance of risk assessment on an individual level, but also as we pair this to intensity of therapy. I already mentioned that we want to identify the patients who are at highest risk because we will have the greatest net clinical benefit when we identify these individuals. We use global risk assessment tools as a starting point for risk assessment with our patients, but not the end. We should focus on those at moderate to high risk to optimize the benefit of interventions, while at the same time minimizing the potential side effects or unnecessary therapies in those individuals. And although relative risk reduction is the same, I mentioned absolute risk reduction is higher for those with a higher baseline risk. So I'm going to start out here with an audience response question, and you have these little clicker pads before you, so please pick those up. This will be important for us to get a sense of, for those of you in the audience, what you're doing in your daily clinical practice, because it also will lead us to our discussion later on when we have the panel. So which risk estimating tool do you use typically in your clinical practice? The Framingham Risk Score, the World Health Organization America's B Risk Calculator, the ACC-AHA ASCVD Pooled Cohort Risk Calculator, or the SCORE. And then the last choice is none of the above, that you don't routinely do a formal absolute risk assessment. You may guess the risk, saying, I think this is a low-risk patient or a high-risk patient, but don't formalize it. So if you pick up the clicker, and I think I just started the clock, I hope. It's at 15. One more. There we go. So please enter on the pad. Okay. Thank you all. So if we look at our current audience here, we can see almost half of the audience is using a Framingham risk score. About 10%, the World Health Organization America's B risk calculator. We have a quarter of the population, the audience here, using the ACC-AHA risk estimator, 7% score, and 10% still use no formal risk assessment. And I will tell you, first of all, congratulations that the majority of all of you start your encounter with a patient with a formal risk assessment, because when I had given talks like these years back, it was much less frequent. So it tells us that the penetration of risk assessment is improving. So I want you all to think about this patient here, and we're going to use this patient as a thread throughout the rest of my discussion. So think about this patient. I want you to analyze their risk, and if you do have, how many of you, just hands, have a risk assessment tool on your mobile phone where you carry it with you wherever you go? So a lot of hands too, and this is a definite improvement from years back where in the clinic it was very difficult to try to access a risk assessment tool. So this 60-year-old man, he has no ASCVD, so primary prevention, but he smokes, he has hypertension, he's taking medications, he does not have diabetes, he has elevated blood pressure, his systolic blood pressure is 160 millimeters of mercury, his total cholesterol of 200, his HDL is 40, and his LDL is 140 milligrams per deciliter. So as you begin to calculate risk by whatever means you use, we want to think about his 10-year or absolute risk. Would we treat this patient with a statin? What would be the potential benefits, risks, and side effects? Would you treat this patient with other therapies? Other therapies might be an aspirin for primary prevention, intensification of his blood pressure therapy, and importantly, lifestyle and behavioral approaches, his smoking, his diet, his exercise. We don't have a BMI or waist circumference, but you might want to think about that as well because of his metabolic profile here. And then how will we discuss the benefits versus side effects of statins and other therapies with this patient? So I know in Espanol es tiburón, so it is easy to tell that this kayaker in the yellow kayak, he's high risk, right? No question. But how do we determine which of our patients are at high risk? Because sometimes when we guess wrong. And so we need to learn how to utilize a population-based risk tool. And so how do we assess population risk or absolute risk? These are traditional risk factors on the left, and this is from Framingham, the general CVD risk calculator, since 50% of you use this as your primary tool today. The factors we import are age, gender, total and HDL cholesterol, systolic blood pressure treatment, diabetes, and whether the individual is a current smoker. And so our 60-year-old man has most of these risk factors. The risk assessment tools differ, as I will demonstrate, in the factors that we input, although they're really more similar than they are different. But they also differ in what the risk assessment tells us. And so with Framingham, the endpoint is both fatal and non-fatal MI, angina, fatal and non-fatal stroke, TIA, claudication, and heart failure. So a comprehensive cardiovascular risk. For the 25% of you that are using the ACC-AHA risk estimator, you can see again the same risk factors as we put into the risk equation in Framingham are seen with the ACC-AHA risk estimator. And we again are calculating a 10-year risk, but this is a risk of fatal and non-fatal MI and fatal and non-fatal stroke. And so it misses some of the other endpoints that Framingham captures. When we put our 60-year-old man into the risk estimator, we find that his 10-year ACC-AHA ASCVD risk is very high. It's 26%. And so this is an individual, much like the kayaker in the yellow kayak that the shark is approaching, that we can't miss. We can't miss identifying a man like this because we know our risk reduction efforts will have very significant impact on his risk. some of you are still using SCORE. And what I do want to point out is that there's no one risk assessment tool that is best or right. But the most important thing you can do is use a risk assessment tool, understanding that all of these tools have limitations, and they're all the starting point of our risk assessment. So in SCORE, finding the nearest cell to the patient's age, their cholesterol, their blood pressure, and then establishing their 10-year risk here, which also includes sudden cardiac death. And it's a fatal risk score only. So looking at our patient here, his 10-year risk of a fatal cardiovascular event is 14% using SCORE. There we go. And then lastly here, the World Health Organization, America's B. If we utilize this risk assessment tool, our patient's risk over 10 years of a fatal or non-fatal CVD event is between 30 and 40%. So whatever risk assessment tool you started with, we get the same information that this 60-year-old man is high risk. And a high-risk patient warrants our most intensive and aggressive risk reduction and preventive efforts. This table here just gives you a sense of these risk scores, how they differ. But as I told you earlier, these risk scores are much more similar than they are different. The risk factors we impute are similar, and there are other risk scores out there that have other factors that we can utilize. The endpoints or predicted endpoints differ, and so whatever risk score you use, you should be familiar with what are the endpoints you're predicting when you have a discussion with your patient. There we go. So we're going to do one more audience response question here, so get your clicker pads out, have them ready. Which of the following variables is not included in the risk scores I reviewed here? The choices are gender, total cholesterol, age, a family history of premature cardiovascular disease, and systolic blood pressure. So go ahead and get your pads ready, and please enter your choice. Wow, that happened. All right. I thought 2 clicks. 1, 2. You know what? Maybe everybody did that so quickly, but I saw D was at the very top there, and there may have been 1 or 2 with E, but so D is absolutely the correct answer here, a family history of premature cardiovascular disease. The risk scores that we use all are beneficial in that we have a starting point to assess absolute risk for a patient-clinician or a clinician-patient risk discussion. But these risk scores have limitations. These are population-based risk scores used for individual patients, and so they are, in their very nature, imperfect. Some of the imperfections include that we don't ask a detailed family history, and we don't include family history in that risk score. Risk scores may not accurately assess risk in all ethnic groups, and risk scores are telling us about risk at a single point in time when indeed risk factors exert their risk over time. So that would be like an integral, cholesterol or blood pressure or your weight. Over one's lifetime, the risk is affected continuously. And risk of other events in some of these risk scores are not portrayed, like peripheral vascular disease, heart failure, or risk for revascularization. And so when uncertainty exists, the risk score is a starting point, but not an end. And so we have many other tools at our disposal to think about reclassifying risk or better classifying risk in those who are at low to intermediate or intermediate risk. There we go. I really like this. This is a construct I use in our cardiovascular prevention clinic when we teach our students, our interns, our residents, or fellows, or our colleagues. And I call this the pyramid of cardiovascular risk assessment. The base of the pyramid is a risk assessment, a 10-year absolute risk. And so this is the foundation of our risk assessment, but it shouldn't be the end of our risk assessment. We should be taking a detailed family history of premature cardiovascular events. As our previous speakers pointed out, we should not ignore a metabolic risk because sometimes these individuals can fool us. In all of our patients, we should comprehensively assess these three factors, but beyond that, we can consider selective use of whether it's biomarkers or imaging or other techniques that may help us better understand our patient's risk. This is from the ACC-AHA Risk Assessment Guidelines, and this is the evidence-based 6 factors that we can consider to think about additional risk classification in our patients. So if their LDL is above 160, if they have a family history of premature cardiovascular disease, age of onset less than 65 in a female, first-degree relative, or 55 of a male first-degree relative, they have an elevated biomarker, C-reactive protein, and I'll be interested during our panel discussion to see whether you utilize these type of markers in your risk assessment. If you had evidence of subclinical atherosclerosis, so a cardiac CT calcium score with an absolute score above 300, or you're in the 75th percentile for age and gender, you have an ankle brachial index less than 0.9, indicative of peripheral vascular disease, and the last one comes back to what I pointed out earlier, the elevated lifetime risk of cardiovascular disease. The last part of my presentation will focus on putting risk management into practice. We're going to come back to the 60-year-old man who we now are very concerned about. We've calculated his risk, and on all the risk assessment tools that we could use, he consistently is at a very high risk level. We pointed out 26% ACC-AHA 10-year risk, his 14% score risk, his WHO risk of 30 to 40%. All right. So what do we want to think about in this gentleman? We know he has significant multiple cardiovascular risk factors. We've established his 10-year risk. We want to think about strategies to reduce risk, lifestyle and behavioral approaches, thinking about a statin and having a discussion with this patient about the benefits, risks, and side effects, and then other potential therapies like an aspirin for primary prevention, but not neglecting his smoking and lifestyle factors like diet and exercise. There we go. This is a paper that we published in JACC a few years ago, and also a paper that Seth Martin at Johns Hopkins published to think about what is a meaningful clinician-patient risk discussion. This emphasizes the importance of the initial discussion we have with our patients, but also the longitudinal discussion we have over time in a primary prevention individual. And so maybe at the first meeting with this patient, you would talk about their absolute risk, your concern about their risk, certainly thinking about his smoking and lifestyle factors, and deciding whether or not you want to begin to have a discussion about medical therapy. What we pointed out in this clinician-patient risk discussion is after we assess risk and discuss risk, we want to really communicate this risk well, but understand our patients' concerns, their preferences, and really focus on shared decision-making. This is a partnership between the clinician and their patient, gaining their trust, understanding that our major focus is on safety and trust. And then Seth Martin's paper pointed out what are called the 5 Ps. So the 5 Ps are the patient's preference, precision. So how precise is this risk estimate, understanding that all risk assessment tools have limitations. We want to focus on their participation in their own care, potency of agents such as statins, and then price. Are these drugs affordable, and are these drugs medications that patients will adhere to and maintain throughout the course of their treatment? This shows you the central illustration from this same paper here, the clinician and the patient assessing risk, discussing options, including lifestyle changes, and initiation of medical therapies. And it can be beneficial to use visual aids. It's very difficult for many patients to understand a concept such as absolute risk, let alone clinicians or physicians. And so these little pictorials where you can show out of a population how many of these individuals would go on to have an event, and then show them how many would go on to have an event if they were to start on medical therapy. So we've reviewed several things here today regarding cardiovascular risk assessment, the approach to that risk assessment, and utilize the case of the 60-year-old man to highlight that comprehensive risk factor reduction is the key to primary prevention, and that we need to mirror the intensity of our preventive efforts to the individual's absolute cardiovascular risk. Risk scores are a tool to start the risk assessment and to utilize in a discussion about the clinician and the patient having a plan for their care over time. And then the last point is that risk discussion and cardiovascular prevention should occur, as I mentioned, throughout the care plan. And this is something that is really critically important for aggressive and appropriate primary cardiovascular prevention. So muchas gracias. Thank you for the opportunity to speak with you here today. These two photografias, the first is, this is the university where I work, Emory, and our main campus. And you can see how Atlanta is really a city that is carved into the forest. So here's the main city here, and you can see still many trees in Atlanta. And right now in our country, it's fall. And fall in Atlanta is, very beautiful. So lots of leaves changing. This is about an hour from where I work in the city. So again, thank you.